Hello and welcome to the latest Speech and Language Therapy COVID-19 Patient Pathway webinar. This series of presentations forms part of an essential resource for speech and language therapists nationally and internationally to inform and support clinicians during these unprecedented times. Today, we'll be hearing about laryngectomy care and how it's had to adapt to ensure patients and clinicians are safe during this pandemic. I'd like to echo what our CEO, Kamini Gadhok, has previously said, and is that working for the professional body, we're daily struck by the dedication, creativity, and bravery of all our members to continue to deliver high-quality care in new and unusual ways. I'm delighted and honoured to be involved. Next slide, please. So my name is Judith Broll. I'm the Director of Professional Development here at the Royal College of Speech and Language Therapy. I'm a speech and language therapist by background. I'm not an expert in laryngectomy, so I am looking forward to learning as much as everybody else. Next slide, please. I am also delighted that we are able to not only hear from clinical experts from speech and language therapy working in this field, but also to hear from two patients who are living with laryngectomy during this COVID pandemic. So I'd like to start by introducing Leslie Flanders and Annie Humphries, who will be talking later on with our presenter, Dr. Margaret Coffey. I would also like to present Mary Lee, who is Consultant Clinical Lead Speech and Language Therapist in Head and Neck Cancer, who works at University College London Hospitals. I would also then like to introduce Katherine Behenna, who's the Clinical Lead Speech and Language Therapist in Head and Neck Cancer, who's working in Nottingham University Hospitals, and Dr. Margaret Coffey, Clinical Service Lead Speech and Language Therapist working in Head and Neck ENT at Imperial College Healthcare. I would also like to welcome Grania Brady, who's a speech and language therapy specialist working at the Royal Marsden NHS Foundation Trust, who's going to help on the panel with the questions at the end. I'd like to now hand over to Rebecca for some housekeeping.
Hello everyone. You'll see that on your screen you should be able to see a chat function, so I'll be on hand throughout the webinar. If you have any technical issues, please do get in touch using that button. We'll also be taking in questions for our speakers throughout, so if you have any questions you'd like to ask, please do send these in via the Q&A button that you'll also find if you hover on your screen. This event is being recorded, so you'll be able to find it on the RCSLT website after the webinar has taken place, and you'll also find a survey that we'll share after the event, so please do fill that in. Any feedback is gratefully received, and as I mentioned, I'm on hand to help with anything that you need. Thank you. Passing back to Judith now.
Thank you very much. So by attending this webinar, as you can see from the slides, we are going to understand how in- and outpatient laryngectomy services have adapted in response to COVID. We're also going to understand more about the use of PPE with laryngectomy services, which, as we know, is extremely important. We're going to hear about the new ways of working to support laryngectomy patients, hearing from them directly, and how managing their patients' welfare and well-being is going during this time. So without further ado, I'd like to hand over to our first speaker, who's Mary Lee. Thank you.
Hello, everybody. Thank you for having me. I'd like to thank RCSLT for allowing us this opportunity to share our practice at UCLH, which has definitely had to change a little in response to this crisis. Next slide, please. So right at the beginning, when all of this started, UCLH was identified as one of the centers for COVID, which was going to be managing the COVID positive patients. So we knew right away that altered airways, bringing them into hospital, was not going to be the way to go forward once this happened. So we looked around for guidelines and policies to see what could help us establish a new way to to support our laryngectomies. At that point, policies were coming out fast and furiously, so we looked at the ones that were most appropriate to us, and they included the RCSLT guidance on PPE. We found a letter of endorsement from various UK organizations identifying neck breathers as shielded patients, which again informed us to make the decision not to stop all our outpatient clinics. And we looked at the RAG rating developed by Guy's and St. Thomas's Trust on risk assessment for voice prosthesis changes. Thankfully, when we looked at our own RAG rating, which we developed quite recently, it was very similar. So that gave us a shot of confidence. Next slide, please. So what were we doing pre-COVID? Well, at UCLH, we have scheduled outpatient laryngectomy clinics, and in those clinics, we would see 10 to 15 people on a week. We had limited drop-in service, and only for emergencies, and that only involved voice prosthesis dislodgement. We would manage, if anybody phoned in with a voice prosthesis that was leaking, we tried to troubleshoot that over the phone and possibly put them off for 24 hours so we could attach them to a clinic and have a much more organized approach. In voice prosthesis dislodgement during business hours, obviously that's a priority. At UCLH, we have an out-of-hours policy for voice prosthesis dislodgement, so that if somebody came in with no voice prosthesis in and we weren't there, there's a policy that's available to all staff to follow until we get back in. So what would we do in our scheduled outpatient clinics? Well, obviously we'd review voice prosthesis and change them as necessary. We saw our patients on our early voice prosthesis failure pathway. We would see them fairly regularly using our protocol, which we developed with support from Sarah Stevens' team in East Kent. We would see them for communication review of any type of communication, and obviously swallowing review. Next slide, please. So when we heard the news that UCLH was going to be turned into a COVID tower, the team sat down and tried to get in front of this a little bit so that we could support these patients in a very planned way, with some front-end thinking on what was going to be the best strategy to manage going forward. As I said before, we had to cancel all our regular outpatients, and that including all patients, including laryngectomy. Patients were notified via letter with detailed explanations for the cancellation. We collated a database of all our active patients, including their communication method, and if they had SVR, the date of last change of voice prosthesis. Because we were stopping all our regular outpatient appointments, we divided all the laryngectomies between us so that we could initially phone them to let them know we were still here, to check on the status of their voice prosthesis, their eating and drinking, general health, etc., etc. Interestingly enough, a number of patients came back and said, well, they were very pleased to hear from us because they thought we were, quote, closed. So they were very pleased to know that we weren't in fact closed and that we were here to support them. We then discussed with them how to go forward and what kind of support they needed from us in terms of going forward in the absence of regular face-to-face contact. Some of the patients said, leave us, we'll be fine, we'll contact you when we need you. Some other patients said, I need a weekly call. Some others said a month. Some said, please contact me by text, etc., etc. So in discussion with each individual laryngectomy, we decided how to go forward with their support. We sent letters for all laryngectomies to their GPs, requesting prescription of thickeners, and underscoring the importance of paying attention to getting their prescriptions for their HME systems done promptly so that the distribution companies could get them out to the laryngectomies. We requested one of our ENT consultants to send a separate letter to the GPs outlining the vulnerability of laryngectomy patients, and again underscoring the importance of not delaying on the HME systems. We also sent all voice prosthesis users plugs to use in case leakage commenced. Next slide, please. So we wanted to avoid changing voice prostheses during COVID, as per all the recommendations from various bodies. As we know, I mean, you know, we were all very rigid with anxiety for our laryngectomies because they're a special caseload, and we have very close relationship with all of them, and I'm sure that's true for everybody, no matter what service you're working in. And we encouraged all our laryngectomies to defer and delay if they had a leaking voice prosthesis by using the thickener and the plug. However, early on in the piece, we had a number of patients coming into A&E despite our best efforts because they had trouble with their prosthesis. A&E is not a very friendly place to manage a leaking voice prosthesis just because the systems aren't set up for it. It's a dangerous place for people with laryngectomy to go to these days because everybody goes there, and as an altered airway, they are at increased risk. When we're trying to manage them in A&E, it's a very uncontrolled environment from our perspective. We don't have our kits. The rooms are generally not set up the way that we need them to be for optimal management of the voice prosthesis. And it was very stressful on everybody involved managing this, and took, frankly, hours. So on the back of that, we sat down and said, right, so, you know, what are we going to do about this? The other patients who were very much at risk of not, when they don't come in, are the people who were on the protocol for management of early voice prosthesis failure. We consulted with our colleagues in microbiology, and they were of the opinion that there is an increased risk of distant infection from bacteria, because although the bacteria doesn't adhere to the silicone of the voice prosthesis, it can adhere to the actual candida. And so leaving a foul voice prosthesis in place for an extended period of time means that bacteria can attach to the candida and increase the risk of further infection. And of course, there's always those patients whose access to the voice prosthesis is limited. They can't see, they don't have very good manual dexterity, and they just can't insert a plug, which even with a thickener, they're at increased risk of chest infections. Next slide, please. So having sat down and thought about this and talked about it many times in our CPD, we then decided, well, there's going to be some patients we are going to have to do voice prosthesis changes with. And so again, we need to get ahead of the process and think about it and plan it so that it's done in an optimal way, so that the risk to the patients is as minimal as possible and the stress on us is as minimal as possible. So we evaluated each case on a case-by-case basis, not ever alone. It was always collaborative with other members of the team. Sometimes that included ENT, sometimes not. But when we decided to bring a patient in, it was done with a lot of thought and planning. Right away, we made a decision for no prophylactic changes because the risk-benefit wasn't worth it. And initially, as I said before, you would troubleshoot the leakage via the phone or video. Normally in our clinics, we would see the patients in our clinic room attached to the head and neck ward in the hospital. Clearly that was not a way forward, and we're in the fortunate position of being able to use a clinic room in the Macmillan Cancer Centre rather than the hospital, in a room that was originally designed for laryngectomy valve changes, in fact. We attached all our appointments to ENT clinics. I mean, you don't need ENT backup most of the time, but when you do, you do. So we wanted to make sure, because these are trickier times, and the patients we were bringing in are trickier patients in terms of managing their TEP and their valve. So we made a decision to only see patients when we had ENT backup available. We instructed the patients either to take personal or hospital transport, that they were to stay away from public transportation, as again, that increased their risk. We asked them to wear face masks, plus their stromal HME system. We were in full PPE, and the rooms were all amber cleaned post-change. The fact that we required amber cleaning of the rooms meant that we really needed to be cognizant that that room was then out of commission for the rest of the session while it was amber cleaned. So when in planning having these patients come in, we really try to limit it to one per session, because otherwise we were knocking out a room that may need to be used for other things. Next slide, please. And that's the PPE kit and our room. So all you can see on the list of the things that we wore for our PPE plus double gloving. You can see the room with the overhead light just above my head. We're a bit spoiled for choice as to whether we put the patient in a chair or on a bed. The suctioning and oxygen equipment is just there to my left. That room also has double sinks for hand washing and a separate one for equipment cleaning. Next screen, please. So what are our top tips for safe, efficient voice prosthesis changes in the COVID environment? Well, first of all, you have to agree with ENT in advance that they're available for backup if required, even though we do see them in the same clinic that they're in. It's helpful if they know that the patients are coming in, so that they know they may be called on. We have had to call on them a couple of times, particularly in cases where there's extensive granulation, just to have a medical eye on it. So we've been very grateful for their availability and their backup when we've needed it. You must inform the site, so we would contact the Macmillan Centre and ask them to reserve that particular room for us for a period of time, because it has suctioning, overhead light. They provided a full PPE, and they also provided a donning helper. So you can't do that at last minute. So we generally give them 24 hours notice before we bring anybody in. We prepare all our equipment before donning the PPE, including preloading indwelling voice prostheses into gel caps. You just can't do that with 2 pairs of gloves on. Well, I can't anyway. So we try to, as much as possible, have everything there so that we don't have to A, open the door once the patient is in and we start the procedure, and B, use a lot of healthcare workers running around getting us stuff that we forgot to get in advance. Patients don't enter the room until the full PPE is donned, and doffing occurs only when the patient has left the room. And I'm sure you guys all know this, but doffing, you take everything off in the room and leave it there except your mask, which you take off outside the room and dispose of into a clinical waste container. Next slide, please. That's the kit, which I'm sure you're all familiar with for voice prosthesis changes. The big white bag is our dilator. We plug, clamping forceps, gel caps and gel, the loaded voice prosthesis, flushing and brushing equipment, and our colored water. We also had narrow French gauge catheters available next to the suction equipment if we needed those throughout the procedure. Next slide, please. So what are our outcomes to date? Well, since the mid-March, we've actually done 15 face-to-face appointments for voice prosthesis changes. They seem to be coming more rapidly now because, of course, we're into this around 8 weeks, and often the valve life is around 8 to 10 weeks. We've had 12 successful, safe voice prosthesis changes. We've lost 3 tracks, and interestingly enough, all these patients were on the pathway for early voice prosthesis failure and presented with a significant amount of granulation around the TEP. 2 patients had significant donuts, and by the time they came into us, the tract was lost. Although the voice prosthesis remained in place. The 3rd person came in with his voice prosthesis in his hand. Thankfully, it was in his hand and not in his lungs. And he presented with globular granulation, completely occluding the front of the TEP. Now, normally we would see these patients fairly regularly, so every 2 weeks, to monitor granulation, to monitor medication, to monitor their process through the pathway. And when we couldn't do that, it's interesting that the only tracts we lost were those patients on that pathway. Now, who knows, they may have lost their tracts anyway. We don't know that, but I think it's a significant thing that the only tracts we lost were the ones who were more complicated and had early voice prosthesis failure and were on an anti-candida pathway. All our patients complied with requirements for our face-to-face appointments. We've had consistent testimonials from patients regarding our support, saying that actually knowing we were there reduced their anxiety, and knowing that they could contact us at any time, and knowing that we were keeping a wary eye on them from afar, made them all feel a little bit better about managing during this very challenging time. What we are finding is that there's ongoing requirements for telephone and video contact for support of these patients. And actually that's bringing everybody's anxiety down, including ours, because of course we worry about them. Our non-English speaking patients prefer to contact us if they have problems. We have offered a telephone interpreter service, but they prefer to contact us as and when, and that's absolutely fine. Next slide, please. So where do we go from here? Well, we're going to carry on doing what we're doing. We are involved in the prospective national data collection, which is sponsored through the Head and Neck Clinical Excellent Networks and run by Rogan Gavender and Joanne Patterson. So we are contributing to that data collection, which is going to occur across 6 months, is occurring across 6 months. Currently, there's 40 centres signed up across the UK. I would encourage those centres who haven't signed up yet to strongly consider it. As the more data that is collected, the more evidence we will have to go forward in our practice, and the more robust the data will be. The contents of the fields reflect the concerns expressed through our base camp regarding this very vulnerable patient population. Part of the purpose is to identify the proportion of COVID patients, and they are collecting morbidity and mortality rates. So I would encourage as many centres as possible to be involved in this, because as I say, it'll give us a little bit more evidence in which to go forward post-COVID. If anyone's interested in getting more information on this, then Joanne and Rogani's emails are at the bottom of this slide. Next slide, please. And now that's my bit, and I will turn it over to Katherine to tell you about the new laryngectomy experience during COVID.
Okay, thank you very much. So in this section, I'm going to talk about how COVID-19 has led to sudden changes across the new laryngectomy pathway, the impact of those changes, and consider how we can work in new ways and how these are emerging as a result of COVID. New slide, please. So across the East Midlands, we have had a small number of patients who have come through for total laryngectomy during this COVID-19 outbreak, and we've seen changes right across the patient pathway. We're interested to know the experience of other centres. So in the pre-surgery phase, when we're often meeting patients for the first time, staff are wearing full PPE and face masks, making it difficult to communicate, but also very difficult to develop the rapport that we normally would with patients who are often understandably very anxious and who are fearful to come into the hospital for diagnosis and for planned treatment. At that stage, patients may be without some of their family support, sessions may be shorter, and the clinic environment is looking different. Rooms are emptied of any extra furniture or equipment to facilitate deep cleaning. And our expert volunteer laryngectomy visitors, who've always provided an invaluable service, reassuring and preparing new patients, and for whom new patients often say this is a turning point for them. These patients can't come to the hospital anymore. And there have been changes too in surgical practice. The Barno guidance in March recommended avoidance of primary TPs and free flaps. So we're now preparing all new patients for laryngectomy without primary puncture and without a timescale as to when they may be able to have a voice prosthesis. And discussion around this is now opening up in our region as we're into week 8 and coming through some of the COVID phases. And it's worth noting that anecdotally some UK centres have continued to offer TPs and place voice prosthesis at the time of surgery. And the inpatient stay is also different. Patients tell us how difficult it is not to be allowed visitors. To mitigate aerosol risks to other patients, patients are nursed in side rooms and only see staff in face coverings. And patients may be discharged sooner, although the numbers are too small to generalise at the moment. And post-surgery, hospital appointments have been reduced, changed to phone follow-up and support where possible, with patients obviously spending a large time between surgery and radiotherapy in almost complete isolation at home. So what are the impacts of these changes for patients? Next slide, please. So for laryngectomy patients, clearly communication is always key. PPE itself presents an additional physical barrier, training patients to use an electrolarynx behind a face mask without being able to model articulation or show cheek placement can present us with new challenges. As an unexpected consequence of COVID, the head and neck wards have in fact been quieter than usual, allowing patients to be seen more intensively for communication training. But shorter stays have meant that learning hasn't always been maintained after discharge, particularly if family are finding it difficult to understand and to help. Emotionally, patients have felt isolated and anxious. They're worried about their families whilst they're in the hospital, and their families in turn have lost the opportunity to learn about stoma care up close and have also not been able to get used to change communication over the course of repeat visits as they normally would. So instead, they're having to suddenly cope with both the overwhelming relief of seeing their spouse or partner returning home mid-COVID, but also with the shock of realising that they can't now easily communicate in the middle of the national lockdown. And none of our recent patients live alone, but this will of course present more challenges for patients who are shielding and must be considered pre-operatively. Some of our patients also, despite ward training, but these very short stays, once discharged and isolating at home, have understandably been anxious about their competence in managing their stoma and any associated symptoms, and also in managing their family concern about, for example, their new persistent cough. So it's very difficult for families to understand this may not be a symptom of COVID. So the challenges of the current COVID situation are adding to the already considerable burden of adjustment to life after laryngectomy. And of course, as clinicians, we're also encountering all of these challenges for the first time and are having to learn alongside patients, adapting our services at speed. And of course, some of that is learning as we go. Next slide, please. So, given that it seems likely that COVID is going to be with us for a while and that we're going to have the clinical restrictions and safeguards for the foreseeable future, what new ways of working are emerging? The first and most important point seems to be that we're in partnership with our patients in extraordinary circumstances. None of us have ever experienced anything like this before. And really keeping the patient at the centre of our decision-making in a partnership seems crucial. In Nottingham, we do have some experience of working with laryngectomy patients as partners. In 2014, we had an enhanced recovery pathway for laryngectomy patients, which was piloted on our head and neck unit with the aim of supporting early discharge sometimes less than a week post total laryngectomy surgery. Subsequent patient interviews by Anna White, research clinician in our team, found that high quality education and support were key to developing patient confidence and enabling a successful early transition from hospital to home. And in the absence of these, patients experienced extreme anxiety and feelings of loss of control, and some needed to return to the ward. And as a result of that study, we made some changes. We now use a patient-held laryngectomy information and skills checklist to encourage patients to take an active lead in directing their own care early in the pathway. And we also have a highly skilled specialist airway nurse who visits patients very early on after they've gone home to help them make that transition. But of course, in the middle of this COVID outbreak, such home visits are also not going to be possible, although our nurse is still going out if it's felt to be an emergency. So in light of COVID, we're identifying and signposting more to online and digital resources to continue this training and promote confidence for our new laryngectomy patients. And I think development of training videos on the various aspects of essential laryngectomy care will be high on our agenda. And if any other services are preparing those, be interesting to pool resources. And secondly, we need to consider communication options. So one of the things that we've all noticed is that COVID has highlighted the dependence on hospital services that can accompany voice prosthesis use. And it's likely that many of us may need to consider a change in practice going forward to encourage more patient independence. At the consent stage, we need to inform patients about the full range of communication options, including esophageal voice, electrolarynx and electronic apps. And when we do return to primary TEP, we're going to need to ensure that patients make an informed choice with the understanding that increased hospital attendance for voice prosthesis management may bring increased risk of COVID exposure. For those patients who aren't able or suitable to take on self-changing at home, travelling to the hospital, possibly on crowded public transport, may now bring an unacceptable level of risk. But I think perhaps the greatest innovation that we've all seen over recent weeks has been the sudden explosion in telehealth within all fields of medicine. Management of patients by phone or video call has become the new normal for the majority of outpatient services, including the GP and many at hospital. Phone triage is being used to gather information about new referrals, about urgency of treatment, and to provide early management in some cases. And as Mary said, for existing patients, telehealth can be used to provide ongoing rehabilitation and support and allow active monitoring, and in some cases to prevent hospital admissions. And it's worth noting here that telehealth for head and neck cancer patients isn't a new idea. Services in Wales were at the forefront of remote laryngectomy rehabilitation some years ago and demonstrated impressive results regarding patient and clinician satisfaction, cost savings, and the reduced need for patients to travel to specialist centres. Some other centres in the UK have followed suit and prior to COVID had engaged with telehealth for some of their laryngectomy caseload. But for many of us, the use of video calls has been a fast, steep learning curve, and centres such as Purdue in America and the Queensland team have shared resources, principles and ideas over recent weeks. Doctors Liz Ward and Claire Burns have published extensively regarding telemedicine for head and neck cancer patients, and although theirs is generally a hub and spoke health facility model to work with dysphagia patients, some principles are translatable to home telehealth for laryngectomy care, and their resources are currently generously being shared online. So there are a number of suggestions for how we can use telemedicine across the new laryngectomy pathway. At the pre-operative stage, instead of seeing staff in masks and without family support, pre-surgery counselling could be made in a joint video call by the MDT team in socially distanced rooms, with the patient at home and family members also able to participate by joining the call. Our patient volunteer is now ready to make video calls on his iPad remotely as part of patient counselling pre-surgery, although we've had to remember that his lived experience of surgery and recovery prior to COVID will be somewhat different to that of new patients. During the inpatient stay, we're realising that MDT members can help patients to call family members at remote visiting times to demonstrate stoma care or communication training and to answer relatives' questions so that they feel more involved. And prior to discharge home, importantly, family can be helped to understand the impact of surgery. And after discharge, if we see telehealth is already helping the MDT teams to keep in touch with patients and allow us to assess the need for management of the stoma. But there are drawbacks of telehealth, and I think those of us who have started using it will agree. The first is connectivity. The speed and the strength of the signal affect hugely the success of that call. And importantly, not all patients have access to devices. I found an interesting statistics that the Office for National Statistics reported in 2019 that while 100% of 16 to 24-year-olds had access to the internet via a smartphone, just 40% of those aged 65 plus had that access. But we must try to find solutions to ensure equity of access. And there are practical issues. So whether a call is successful can be dictated by the size that we appear on the patient's phone and whether they can see us properly. I've had connectivity issues twice this week in that regard. The age of the patient's smartphone, whether it supports the platform that we're using, is important. And patient and therapist skill in using the technology. And there are also important issues about governance, security and confidentiality. And the RCSLT are currently preparing information to help guide members on this with resources that should be available on the website by early next week. So, as a final thought, speaking to new laryngectomy patients this week, I've been struck really by the enormity of the extra challenges that they face through this healthcare crisis. And the ongoing threat of COVID means that we will be making lasting changes to our services with and for them. Opening up discussion and debate about the best ways that we can do this and continuing to share and learn from each other throughout this is going to be crucial. None of us have the answers and we're all still learning. I'd like to hand over to Dr. Margaret Coffey.
Thank you, Katherine. So thank you to RCSLT for facilitating this webinar. This presentation will focus on managing patients' well-being during the crisis, and I'm delighted that I will be joined during this presentation by two patient volunteers, Humphries and Leslie Flanders. I'm going to start with some slides, just providing some background first. So we've had presentations on outpatient management during this webinar and on the experience of new laryngectomy patients. And it's very clear that we've a new landscape in terms of how SLT care is provided to laryngectomy patients as we go through this crisis and also plan for the recovery and beyond. So these changes in how we provide our service have significantly affected patient experience. Within our team at Imperial, we've had feedback from patients highlighting issues around well-being. Some patients have expressed frustrations that the COVID crisis has meant a focus on the physical effects and symptoms of COVID and around infection risks and the need to socially isolate. But there appears to have been little emphasis on mental health. So if we move on to the next slide, please. So I'm going to step away from COVID for a moment and think about what we know already about well-being and head and neck cancer. So we know that many patients adjust well, but for some there's significant psychological distress. So there's a study by Wang and colleagues that indicate that 35% of patients suffer from depression and anxiety. And we know that the psychological distress for head and neck cancer patients can happen along all stages of the continuum of care. So from the pre-treatment stage through to active treatment and beyond, through the survivorship stages. We know that head and neck cancer patients, some experience isolation, some have highlighted a lack of social support. And it's interesting that there's evidence also highlighting the impact, sometimes negative, on carers in terms of well-being. So carers taking care of head and neck cancer patients. And of course, for many patients, there's a negative financial burden going through head and neck cancer treatment. Can we move to the next slide, please? So now focusing on laryngectomy patients, what do we know about the well-being of laryngectomy patients going through treatment? Surprisingly, there isn't a huge amount of evidence around this, although we do have a lot of evidence around the quality of life aspects. But focusing specifically on well-being, obviously many patients adjust well, but for some, they have difficulty with mental health. So I'm drawing here on this slide from work that's been undertaken by Suzanne Singer and colleagues. One study indicated that 6% of laryngectomy patients developed a mental disorder in the first year after diagnosis. Interestingly, male and female patients had an equal frequency in terms of mental health difficulties. Although women suffered more than men from post-traumatic stress disorder and anxieties. And those who weren't able to achieve a voice after laryngectomy, in these studies undertaken by Suzanne Singer, 80% of that group without a voice had dependency issues with alcohol. And these studies highlighted that actually there was very limited support for laryngectomy patients in terms of well-being. Can we move to the next slide, please? So now, turning to COVID-19 and some of the stressors that are experienced by everybody going through this crisis. It's been difficult because COVID appeared to appear quite suddenly, and there was a lot of unpredictability, and there remains indeed some unpredictability in terms of how this infection will develop. Lots of concerns initially and continuing around safety. We've all had to deal with issues around social distancing, and there's been a lot of information, not only through the media, but also through social media channels. So these studies that I've highlighted by Gow and Garfin really illustrate how the information received through media has made some people feel that the effects of information overload, essentially. And there's been the economic impact of COVID-19 for many, with furloughing of jobs and loss of jobs. And we've had to fundamentally change, those of us who work in healthcare settings, how we actually provide care to our patients. Can we move on to the next slide, please? So focusing now specifically on well-being and COVID-19, what do we know? So drawing from the literature, we know that COVID-19 increases stress, that for some patients, but also those in the general population, there's an increased risk of depression and anxiety. For some, loneliness is an issue, and panic disorder can be problematic for some. And interestingly, sleep deprivation may be an issue also for some. And I have just summarized some of the relevant papers in terms of well-being in COVID-19. Can we move on to the next slide? So what about laryngectomy and the specific issues in relation to COVID-19? So there's two fantastic papers that have been published, one from Italy by Parinello and colleagues, and then one from the USA by Hennessy and colleagues, again published this year. And these papers have highlighted the increased vulnerabilities of laryngectomy patients in terms of their altered airway and the potential increase in infection because of that altered airway. Of course, some laryngectomy patients have comorbidities, cardiovascular comorbidities, diabetes, and other comorbidities that may make that patient group more vulnerable to COVID-19 infection. And then there's the impaired mucociliary function, irritation, that patients may experience, and that loss of upper airway resistance may be an issue, and again increase the infection risk. And then if patients do become infected, there may be a higher risk of complications, and also if patients are infected, there may be a higher risk of transmission of viral particles to others. Next slide, please. So there is much that we yet have to learn about well-being as patients proceed through this era when we're dealing with COVID-19. And I'll be talking to our patient volunteers a little further about that. But in terms of possible solutions, and obviously these are emerging, one aspect that our patients have found helpful is registering as vulnerable. So registering through the Government UK website, indicating that a patient is a laryngectomy. This has worked well for many patients. They have received vulnerable status. Some have not, however, and that's also caused anxiety. And those that have not succeeded in being designated as vulnerable can access further help from and support from their GPs to have that vulnerable designation given to them to help with practical aspects like getting grocery deliveries, but also other aspects of care. I want to highlight that Macmillan, Cancer Research UK and the National Association of Laryngectomy Clubs also have resources to support patients during this time. The links for each of those resources are there. We've found with our patient group at Imperial that peer support amongst patients has been very helpful. We're fortunate to have a laryngectomy club at our trust. And as Mary and Katherine have already alluded to, speech and language therapists are providing support to laryngectomy patients, albeit in a different way to usual. And we have found, and patients have fed back, that it's helped with their well-being and managing anxiety in particular to have a virtual sort of open door SLT policy. So even though we're not seeing so many patients face to face, being available by email, by phone, and on other platforms. And we found that it's been helpful to patients to reassure them that we haven't stopped placing voice prostheses forever, that we are still able to place prostheses for some patients, and that we are absolutely moving towards resuming that service again once it's safe to do so. And I wanted to highlight that there is a program taking place next week on Channel 4. So this program's on Wednesday, the 20th of May at 9 p.m. And this program's focusing on how patients and those who are older have been managing through the COVID crisis. And this program is going to feature a laryngectomy patient. So I think this may provide a useful resource, not only for our patients, but also for clinicians. So thank you. Can we move to the next slide? So at this point, what I want to do is now hand over to the experts, so hand over to our patients. So I'd first like to introduce Annie Humphries. Annie, are you there and available?
Yes, sorry, I forgot to unmute. Thank you for introducing me. It's lovely to be able to take part.
So Annie, thank you for taking part. And I know that we've had some discussions about the anxieties that you have experienced over the last few weeks. You told me about your anxieties around going into hospital, around managing care and cleaning of your prosthesis.
Yes, ma'am.
And also,
I'm sorry. Over the care and cleaning, that's a very good point, because I think we get very worried that you may damage the prosthesis by overactive cleaning or by not cleaning properly and letting candida build up. It's very important to keep it clean and also well lubricated with the flusher. And that has been a great concern, so one has had to be meticulous.
Okay. And Annie, you had mentioned about some concerns around going into hospital. How are you feeling about coming into hospital when you are at the stage where you need a prosthesis change?
I'm not worried about going to hospital, I'm just worried about getting there. For me, it is a commuter train, and then an hour on the underground, and then it's the bus ride. But I can walk the distance and avoid the bus. But I'm just now terrified about being exposed to all these people. And if you've seen the recent film footage, the recent film footage where people are sitting in the tube, cheek by jowl now. That's my concern.
So you're concerned about the infection risks around that?
Yes.
Yeah. And I know right now your prosthesis isn't leaking, but obviously coming to the hospital is something that you'll have to deal with as we...
From when, yes.
Yeah, yeah. And Annie, you've also explained to me your frustrations around being designated as an extremely vulnerable person.
Oh, yes, it has been totally frustrating. It started off when I wasn't designated extremely vulnerable, and I knew that it was at the GP's discretion that things are moving on. But I rang the GP surgery, and I just got fobbed off by the receptionist. And quite honestly, they don't seem to know the difference between a laryngectomy and a tonsillectomy, and they don't seem to want to know the difference. Anyway, I was told that the GP would ring me back, which of course he never did. So, and then I tried the websites, and I got knocked back, and then finally I got a text message from NHS England to say that I had been given extremely vulnerable status, and I have got my supermarket deliveries, but then Gov UK say I haven't. So honestly, I don't know. The lack of communication between the two branches of government that are responsible for this is lamentable.
So that's an aspect that's increased anxiety for you and increased frustration.
Absolutely.
So hopefully, though, you have now been designated as vulnerable.
Well, I've not received the letter yet. They told me 8 days ago that I was vulnerable and I would receive a letter, but I haven't got it yet. And also, Margaret, there's another thing that's arisen this morning. I went to my local hospital for a pre-assessment for a oral surgery, and I was told that they would refuse to do the operation because my consultant had put down that I had had it with local anaesthetic and with sedation, and they couldn't do the laryngectomy. It was sedated.
That's really frustrating. And what is going to be the outcome of that? Will you be going back to...
No, they won't deal with me at the local hospital. They say they'll send my details on to another hospital in the same county, but they don't know when this might happen.
Okay, so that's not something that's helping with anxiety levels either.
No, because if I get another oral infection, it will be really quite bad.
Yes, and I know that you've previously said you had some worries if you end up being admitted to hospital around perhaps accidental dislodgement or even removal of the TEP, because perhaps
yes,
yeah, because perhaps
there's real conditions that you are not experienced. No doubt to avoid dislodging it.
Yeah. So Annie, thank you. It's been very helpful to hear about the factors that are influencing your anxiety. Before we finish up this section, is there anything else that you would like to say to the group?
I think I would like to make one point. That's an experience, because I've experienced being at Charing Cross Hospital, where knowledge and care is exceptional, and then being in my local hospital, where if you're out in the sticks, a lack of knowledge is really quite lamentable.
Well, hopefully having a webinar will help with information really to all, to patients,
yes.
and clinicians.
Yes, Margaret, it's all about raising awareness.
Yeah, raising awareness and sharing information.
Yep, absolutely.
Annie, thank you. I'm going to move to Les now. Are you ready, Les?
Margaret, yes, thank you.
So this is Leslie Flanders, and Leslie, thank you for participating. So Leslie, interestingly, you feel that you've coped pretty well through the COVID crisis. So I know that you'd mentioned that you'd previously had a diagnosis of anxiety and depression, but you've had no pressing concerns, although you have highlighted some of the changes that have happened in your working life and in your family life. And also, and Annie, I know, had mentioned this too, just your responsibilities around taking care of older patients. Would you like to talk a little bit more about the effects on your life of the COVID crisis?
Yes, I think the immediate impact of the pandemic was I run a business that has had to close down because I need to go into people's houses to do improvements. So that and my employee, we've had to cancel or postpone jobs, and I don't know whether they will come back. I have no immediate intention of returning to work. until I'm very confident to do so. The added impact on the pandemic is my eldest son, who's at university, has had to come home. And I have the privilege of sharing my home with my wife and 2 sons. So we've used this time to bond as a family, and I'm sure many people have as well. So that's been a quite positive outcome for me, apart from the losing the work. I have, as you mentioned, I have an elderly mum, 93 years old, lives down the road. And that is my main concern, that and my in-laws who live close by too. So it's been quite challenging looking after my mum. But fortunately, my sister's joined there and living there, so that's eased that worry for me. And this time has given me, the time to actually to relax, take a step back from the hectic life that I've lived. There are frustrations, like everybody else, in as much as the planned holidays have been cancelled. My motorcycle tours have been cancelled. But I think we've been lucky with the weather. It would have been a different story if we'd have been stuck in home with the dark days and cold nights, so that's been good. So we've been able to get out in the garden, barbecues, and I've enjoyed cooking for the family, and hopefully they have too. You need to ask them. So I guess that's why I'm coping quite well, and I'm in a privileged position, and I'm not sure everybody else is.
Leslie, that's really helpful. Thank you. Is there any other points that you want to add, or are you?
Yeah, at the start of the pandemic, nobody realised how serious it was, how serious it is. So I had initial concerns over voice prosthesis care. And Margaret, 2 years ago when I had the operation, it's taken a while to get the right prosthesis, and we had issues with the valve leaking very regularly. Luckily, this valve has been in now for 4 or 5 months, and you've taught me how to change it myself, and I've got a spare one here. So with the help of my wife, if this starts leaking, I'm confident and comfortable to be able to change it myself. I had communication from SLT in Charing Cross Hospital with a phone call from one of your staff, which was really helpful, put my mind at rest, and further email communications, which answered all the questions I had. And I think that came quite early, so I've been quite relaxed about that.
So that's helped.
Yes.
Yeah.
And I echo what Annie said about the care at the Charing Cross Hospital is second to none. And like Annie, I've had an incident where I've needed to go to another hospital for an emergency, and the service was woeful there because they weren't experts. But I don't want to end on a negative note.
So I'm sorry that you didn't have such a good experience, but I know there's so many fantastic centres of excellence for managing laryngectomy all through the UK. And I feel strongly having webinars like this helps disseminate information and expertise to all. And I feel it's particularly useful having Annie and Leslie participate in this session. And if I can just try and pull together what Annie and Leslie have said, thank you. Annie, I think you've really highlighted that there are many anxieties that you're experiencing, not only around the voice prosthesis and how you might cope if you came into hospital, but also around practical aspects of your life, such as being designated as vulnerable, getting shopping. And Les, you've had a more positive experience. You've had no pressing concerns in terms of managing your voice prosthesis, but you've still highlighted significant impacts of the COVID crisis on your life in terms of work and in terms of family and taking care of older patients. And I guess the point I'm taking home from this is that every patient is different. Every laryngectomy patient will have different challenges. And thank you for highlighting that to us as a panel and to the group listening. Thank you.
You're welcome. Thank you, everybody.
So what I'd like to do now is hand over to Judith, because I believe there may be some questions.
There are indeed. There's some very interesting questions that have come through, and I think thank you all. I'd like to just echo what you were saying, Margaret, particularly to Annie and Leslie, for really putting into context what it is we were hearing from our panel earlier. And as somebody who is not a specialist in laryngectomy, I think it really gave me a much clearer idea of the macro and micro challenges we have. You have the bigger one, the smaller, but also how extraordinary it's have empowered you, Les, and your family to do your own changes now. I mean, in a way, that's the most extraordinary thing to be able to achieve. And actually, it's a positive workaround. I'm always about silver linings, and I think that is really powerful for all of us to think about working in collaboration with patients that we are with all the time.
I think if you'd have gone back a year, I wouldn't have thought I'd have been able to change it. So I'm delighted.
Yeah, and it's extraordinary. So thank you for that. And in the meantime, we have had some really interesting questions coming through, and thank you, Grania and I have been having some interesting dialogue. I'm not quite sure how long we have for them, so I'm going to sort of start at the top and work. I'm trying to get a focus across the pathway, if I may. The first one really is probably for you, Mary. There was a question saying, have you provided A&E or bed managers with any specific guidance on infection control measures for emergency laryngectomy inpatient admissions, i.e. tracheal COVID swabbing, use of side rooms, etc.?
Well, interestingly enough, we haven't had any emergency laryngectomy admissions. We have had one or two laryngectomies come who ended up being COVID positive. They were managed and sent back home and then monitored very closely in their homes rather than admitting them. The patients, the inpatients, the laryngectomy inpatients, we have had some inpatients who acquired COVID as inpatients, you know, the goal there was to get them back in their homes as quickly as possible. Frankly, I don't know if we were doing tracheal swabs or not, so I can't really help you there. Maybe Katherine may have some more insights on that, but we haven't had any emergency admissions per se.
No, I don't think we've had any emergency admissions of laryngectomy patients in Nottingham either, so I don't know that I have much more to add either.
Margaret or Grania, have got any emergency admission feedback?
So we've had only 1 or 2 patients admitted, but they've been admitted because they've been diagnosed with COVID. They have not been admitted because there's been an emergency around their voice prosthesis. Those patients have been swabbed, and obviously COVID was identified. And I just want to highlight a really interesting paper. It's one of the ones that I referred to in my presentation by Hennessy and colleagues. It's an American paper published this year, just highlighting that there may be issues with swabbing laryngectomy patients to confirm COVID status, and highlighting that it may be helpful to actually swab the tracheal aspirates, not just the nasopharynx. So for those interested, have a look at that paper.
Yeah. Thank you, Margaret. Grania, do you have anything you'd like to add?
Yeah, so we didn't have any emergency admissions just because of the centre that I'm based in, but for any elective admissions, because we have had elective admissions for patients who've needed various procedures done, and they have all had swabs, yes, pre-admission. They wouldn't have been admitted if they tested positive.
Okay, thank you. That's very helpful. Leading on from that, another acute question before I move on to something slightly different. So another question for you, Mary, but interested in other colleagues' comments, is how was it managing clients whose voice prosthesis change took longer amounts of time due to dilatation or more complex difficulties during the change? Did you find that this had an impact on other clients coming in, considering this room was required for an amber clean?
Well, as I say, we generally only try to just book one laryngectomy change a day, so that we wouldn't take up too much time in that room, wouldn't put it out all day. But it's a really interesting point about managing voice prosthesis changes that are more complex when you're in full PPE. Because decision making is definitely affected. Well, certainly amongst our team, it is, when you're all trussed up in all of that gear, and you know your breathing is different, and it does take a longer time to process the information you're gathering, and physically it takes a longer time to sort out the equipment when you've got double gloves and all of that stuff going on. So if you're in the PPE for a long time, and sometimes we've been in them for 2 hours, and that with one voice prosthesis change and troubleshooting and all the rest of it, then it gets really quite tricky for the therapist to manage that, just in terms of your own physicalness, as well as managing the patient and the troubleshooting. So that's the biggest consideration. We never really considered, you know, we got to get out of the room, because obviously it's all about, let's sort out this person first, and without stressing ourselves by being in the PPE for too long. And we just knew that there was no way we could manage 2 of those in one session, so we always just did 1. I don't know if that helps.
Interesting.
But I think we do need to be cognizant of the toll that PPE takes on the wearer, as well as the laryngectomy person.
I think that's significant. Thank you for that. Can I just move slightly sideways about PPE and protective masks for patients? There was a comment that came through around recommended guidance for laryngectomy patients and stomach protection / face masks. I'd like to open up to the panel just to see who would like to comment about that. I think that's an issue. Where did that come from? Was that you, Grania?
Yes, that question did come through. Margaret, I think that's covered in that paper that you mentioned also about stoma protection and wearing face masks. Is that paper, or is it the Stanford paper that covers that as well? But it does actually recommend that laryngectomy patients should cover their face and nose as well as their stoma as well.
Okay. Thank you just for reminding us about that. I'm aware of time, but I just wondered whether there were 2 questions about valve changes in areas which are not in centres. So there's one question around working in rural areas, and there is some suggestion of training up GPs or district nurses to change valves if there isn't any access to speech and language therapy. And there was also another question which was similar to that around whether other people, same thing, could people change it who aren't competent speech and language therapists? Be interested in your thoughts about that. Who would like to take that?
I think in the first instance, it would be preferable to try to train the patient to be a self-changer, because that obviously our goal is to make them not need us. So if that's at all possible, and by thinking outside the box, if we can promote that, then that would be our definite preference. I think it's a reasonable idea to have other professionals change voice prosthesis as long as they can maintain their competencies. And that's always the issue with training anybody else who doesn't do it regularly, is you can't change 1 or 2 voice prostheses a year and do it safely. There's always that issue, is access to ongoing training. This is where I think, you know, that hub and spoke model of telehealth that Australia uses so well may in fact be something that we may need to start to consider, because even, you know, if you have been trained in changing a voice prosthesis but only do 1 or 2 a year, then maybe the option is to video in to somebody who is an expert in that to guide you through it and to be backup, etc., etc. It's not ideal, but I think that we are going to have to start thinking outside the box as COVID carries on. I don't know if anybody else has any opinions on that.
Are there any other comments from the panelists on that point?
I would agree about competency, that you just can't change somebody else to do it who is doing so few changes every year. That is hugely important.
Yeah, I agree. I think there are many things we do which are trained and highly competent for many reasons. I'm just looking through the questions here. There was something around would we go and change in people's homes, which I'm assuming is fairly similar to that. And there was a question around, it was a comment actually, which is quite interesting, around, I know what you were saying, Annie, about your designation as somebody who's highly vulnerable, and there are some of my patients, not all of my patients are keen to be diagnosed, designated as vulnerable, and some of them are key workers, for example. So I think it's an interesting one, and I think it's back to what we were all saying, that every person is different, and that's why it is so important for us as a profession. And I think we are excellent at advocating for people on an individual basis. And just because you receive a letter doesn't mean that you have to agree with it necessarily. That's assuming you do receive a letter from somebody. I would also just like to comment, I've been looking at all these things coming through, that we have actually got some international people on our call as well today, from Australia indeed. So not only are we national, but we are truly international in our webinar. So welcome all, and it's great to have you, and it's great to know that we're all learning from each other. So just wanted to say thank you for that in particular. I think that we are probably running out of time. As ever, we are speech and language therapists, we do like to talk, but I think this has been an absolutely fascinating webinar. And once again, I would really like to thank our expert panel, and more importantly, I would really like to thank Leslie and Annie, who have really made this a special event. We also have somebody from Malaysia on the phone, excuse me, I'm sorry for forgetting that earlier. So thank you all for your time. I hope you found this webinar useful. If I've missed any questions that haven't been addressed today, as ever, they will be answered and put on the website in due course. So thank you all very much for all your time. Thank you for the panel and for the patients, and stay safe and have a good day. Thank you all. Bye-bye.
Thank you. Bye-bye.
Bye.